Thanks. As said, my last name is Buchanan. Everyone can call me Brianne because when you're a PA, there's no great um, salutation to have there. So I usually tell my patients the same thing, just call me Brianne. It's a lot easier. So I think that from what you guys have been having on this series, this may be a little bit different, just being a PA, a little bit different perspective. And I'm going to be honest that I am completely biased towards PAs as a career as opposed to physicians. So understand everything I say is going to be coming from that place. I think probably I have been in practice as a PA for about 15 years. Um, it didn't start out that way, so probably taking a little bit through my career path first, and then I'll get into kind of what I do here with the bone marrow unit and program. So from the age of 3, I was certain that I was going to become a veterinarian. I continued with that until I went to, don't judge me, NC State as my undergrad career as a pre-vet student, and continued in that path until about my sophomore year. So I had worked with some veterinarians, worked with some more at NC State, and just kind of seeing the idea of a veterinarian versus the reality of it, I decided that was not what I wanted to pursue as a career. So about halfway through undergrad, decided to change my mind, but wasn't exactly sure what I wanted to do after that. So explored a few things. Marine biology, that was a no-go. And then was working in a lab for a company that was small in RTP called DNA Sciences immediately after graduation. And while I probably could have pursued a field in the lab area, it was not exactly fulfilling to me, and I wanted to do something more interaction with people. And so while I was there, I actually worked with a girl who was trying to get into PA school, and she talked to me about it, and I said, wow, that sounds really great. I had been tossing around the idea of medical school, had some friends here at the UNC medical school at the time, um, who were big proponents of it and thought it was an excellent school, but it just was a little bit, probably my biggest hindrance was that the time commitment, uh, the investment of medical school was not exactly what I was looking for at that time. It's certainly not just the 4 years of medical school, it's the residency and the whole shebang, and I wasn't entirely sure that was exactly what I wanted to commit to. When I heard about PA school, I was like, oh, that's perfect. It is generally with most schools, a 2-year program. And so I looked into that, realized that it had all the things that I wanted and none of the things I did not want. I was very interested in actually taking care of patients. I had a lot of interest in medicine and science in general, but no interest in writing grants or doing the nitty gritty of the research world of sitting at a desk and plowing through weeks and weeks of trying to get something through. I love research. I think it's wonderful. I'm glad that there are people who do that, but I would much rather be on the clinical side of that, interacting with the patients than behind a computer screen. So that was a large part of why I decided that PA school was perfect. Also, it's a lower commitment, as I described to my husband when I was thinking about going, was, well, instead of a doctorate in medicine, it's like a master's in medicine. You come out with a master's. I believe all the programs now, when I went to school, it wasn't the case, but I think all the programs now are master's programs. And they're generally 2 years. So you have an undergrad degree in biology. Mine was in zoology because I had been pre-veterinary, but generally a science-based field. And then each school has its own requirements. So I applied to 10 different schools actually. My first choice, luckily I got into, which was, we were living in Pittsburgh at the time, but it was actually George Washington University in DC, which was a great school, which was a factor in me applying there, but primarily I just wanted to live in DC for a bit. And so I was very happy to get in there. And 24 straight months, there's not a big Christmas break, there's not a big summer break, you just kind of plow through and then you come out able to practice immediately. So there's no residency afterwards. You get a job and you basically learn on the job in whatever field you go into. Most people that I went to school with did, if you have your interest, you tend to do things like elective rotations in areas of interest, but it's not required. One of the things that I really loved about PA school was that it makes me sound a little bit like a commitment though, but there's just a lot of flexibility. If you go in and you decide that you want to do something else, you can change careers, change jobs mid-career in a completely different field. When I started, I had you have to get some patient care experience before you go into PA school. So I did work as a medical assistant with a gynecologic oncologist for about a year and a half before going into school, and really enjoyed the cancer patients we were working with, but thought, I don't know, I really love emergency medicine. That would be so much fun. I like the show ER. It would just be very fast paced and you'd see all these different things. And then getting through the first year of PA school was all didactic, and then the second year was all rotations. My first rotation was in the ER, and I, I thought, this is definitely not what I want to do. I think also kind of depending on your role in the emergency room as a PA, there's a lot of fast track, there's a lot of suturing, there's a lot of coughs and colds and runny noses. You can have different jobs. Every place has a different job, but it was not what I really wanted to do. Plus, I found that I really disliked knowing someone for all of an hour or two, and then never seeing them again, never knowing what happened to them. So I actually ended up back in the kind of oncology focused world and did a lot of my elective rotations there, and decided that more the cancer world was where I wanted to be. Some of my rotations, because I was up in DC, one of them was with bone marrow transplant at the NIH. So that was nice to have that exposure. And then right out of school, found a job actually in urologic oncology, which is a little different it was at the NIH, so it's a little different there than it is in typical urologic oncology areas. So these are typically prostate cancers, kidney cancers, things like that. They saw primarily one very, very rare disease that they'd fly people in from around the country, not the typical experience you would have right out of PA school. And I did all the urology consults for the hospital, and that was also not my favorite thing. So urology is not the field that I was interested in, but as a PA, I could just change jobs. So actually, after probably a little bit less than a year, I actually moved down to Duke again. So we like this area, and living in the DC area was also a challenge. So we moved here again and lived in Durham, and I worked for a group called the Duke Oncology Network, which is a outreach oncology group. So we were based in Durham. They had 9 clinics around the state, going from, actually one was in Virginia, going from South Hill, Virginia down to probably Whiteville, North Carolina, near the South Carolina border. And we would go to either help physicians that were already in these clinics, or some of the clinics were so small they didn't have any physicians, and we would go and see patients for the day, come back. We never spent the night. We'd always go down for one day at a time. Some of the clinics were 2 or 3 hours away. So we would fly in a small 2 or 4 seat plane that was operated out of Horace Williams here at Chapel Hill. They're not located, the Med Air is no longer located through UNC. They're at RDU right now, but we would fly down to clinic for the day, see patients, come back. Sometimes the social worker would pick us up in her minivan and drive us to and from the airport and the clinic. So it was pretty fun. Some of the clinics we drove to, but it was sometimes a different clinic every day, seeing patients that ranged from colon cancer to lung cancer to breast cancer, sometimes brain tumors, leukemic patients, patients with just blood disorders. We do bone marrow biopsies. It was really interesting, but very, very long hours. The travel was rough and pretty demanding. So I was there for 5 years. I did a lot of administrative work too with them because they were a fairly small group. And so got involved with a lot of the kind of management of the group as well. And then after 5 years, I had a child, and that got even tougher schedule wise. So I actually left and went to bone marrow transplant at Duke. I was there for 2 years, which ironically, one of my PA school classmates was already working in that group. So uh, had someone I already knew in there. So got in, really liked bone marrow transplant. During my time there, had another child, my second one. There's only two. And then again, the kind of the volume of the Duke bone marrow transplant was really high, and so I enjoyed doing that. But I really didn't want to be working full time at that point, and wanted to scale back and kind of focus on my kids because they were very little. So Duke said no. Uh, my coworker there, who I was working with in the same group, was interested in the same thing. And so both of us actually, the UNC group here was actually expanding at the time. Both of us moved here to UNC at the same time and worked with the intention of working part-time for a few years while our kids were little. We've both since gone to full-time. There are 7 APPs in my group, which are nurse practitioners and PAs. And we are a pretty tight-knit group. And so, do you want me to just talk and then we can answer questions at the end, or I can kind of answer questions as we go to whichever?
Yeah, I think the best way to go is just talk and then questions at the end, if that's okay.
Great. I can talk to a wall, and Zoom's kind of like that. So if it gets lengthy, just let me know. But so once I came here, the UNC group has been great. I've been here for about 7.5 years. My group is wonderful. We get along very well. Our newest member of the 7 of us got here around almost 4 years ago. So we've actually have quite a bit of longevity. APPs in general, nurse practitioners, PAs, tend to have a very high turnover rate in groups where there's not great quality of life. For me, quality of life was very important. That had a lot to do with why I went to PA school as opposed to medical school. I like to have a lot of balance, and some things are very important to me. And so, such as like travel, exercise, I didn't want to compromise on something to be spending my time all the time at work. And so, with my job right now, I really like it. I work in a great group. The physicians have a lot of respect for the APPs. We see patients autonomously, but that's not the case in every group. There are quite a few APP positions where the APPs act nearly as scribes, just writing down the visit. There are others where they are kind of worked long hours, not respected, used as kind of I don't know, lackeys for the physician, and for lack of a better word. But every job is really variable. I don't think you can kind of walk in and expect it to be one thing, but it also allows flexibility to look around and kind of find a job that really works for you. And the flexibility too is not just in the schedule, the type of job, working nights, working weekends, working regular shift during the day. You can do different hours. You can basically you can find a job doing whatever you want. And also because I can change fields. If I wanted to get another job, for some reason this one wasn't working out, and I was working in bone marrow transplant, I don't need to move across the country to find the next available job. I could go into another field if I was interested in doing that, or just needed a change at some point. And I really, really like that aspect of it. That being said, I've now been in transplant for 10 years, so I obviously like it here quite a bit. My day is trying to see the best way to do it. We're a pretty varied group. We both cover the inpatient unit of bone marrow transplant and then also the outpatient clinic as well. So we staff 7 of us. We have the inpatient unit covered 365 days of the year. We do holidays and weekends. We work 4 10-hour shifts a week. So we work 8 to 6, which I think is probably by HR not considered an actual 10-hour day, but we get to call it a 10-hour day. And so we work our schedule around just making sure that we cover the unit and the outpatient clinic. And the outpatient clinic, we have our own templates that we share patients on amongst ourselves, but we don't own our own patients. So we see all of the doctor's patients. We tend to follow the patients in the hospital. And then once they get discharged in the acute phase for the first 100 days out of transplant, we primarily see them. They'll check in with their doctor every few weeks to month, which is a little bit strange, but we'll see them sometimes 2 to 3 times a week amongst my various members of the group, and we kind of pass them around. So we end up getting to know the patients really well. That was something that I really like in cancer care, is you get to really be intimately involved with your patients. We have much lower patient volumes, but we do get to really know them and their families, especially their caregivers. Transplant kind of affects a little bit of everything. So for those of you not familiar with stem cell transplant or bone marrow transplant, what we do these days is if you have a diagnosis that qualifies, and primarily we're seeing leukemia, lymphoma, multiple myeloma patients with a few other diseases thrown in there, we will hopefully, with transplant, we're working towards a cure for most of those except for myeloma. And so we will use either the patient's own cells or someone else's cells. We'll give them chemotherapy, which either the chemotherapy is a treatment or the cells themselves can be treatment to basically replace someone's immune system with someone else's. The healthy immune system comes in and takes care of any of their residual cancer. So that's how the transplant basically works. We do not take stem cells from let's see, what have I heard before? Fetuses in garbage bags. We don't steal them from labs. There's a strange amount of misinformation around stem cells. We take them from adults who consent. It's a big part of that. And they're generally, actually, we use the term bone marrow transplant. Rarely do we ever collect stem cells from bone marrow. We can, and we do occasionally. But now we primarily insert just an IV, and we hook a person up to a pheresis machine, which is similar to a dialysis machine, filters the stem cells off. And then they're given back almost like a blood transfusion. So there's no surgery. Another question that patients are asked all the time is, how was your surgery for your transplant? And it's not that kind of transplant. It just goes in like a regular IV, but there can be some big complications. And our patients usually have at least a year or two of recovery afterwards. Their lives can be pretty significantly changed, and they can be in and out of the hospital with us for months after transplant. And so they generally spend the first month with us, and then after that, they can be followed in the outpatient clinic for at least 2 months in the local area for what we call the allogeneic or the stem cell transplants from other people. Those patients are at high risk for infection. They're coming in 2-3 times a week, a lot of times requiring IVs and management of kidney problems, infections, other complications of transplant. And we're doing that almost exclusively. We certainly, I have all of our physicians text, so we will text questions if we need to ask them about patients that are their primary patient, and we meet together as an entire group once a week. But for the most part, we're pretty autonomous, which is really nice. It gets to the point where certainly if there's a problem with a patient, we'll ask a physician, hey, what do you want to do in this circumstance? And I'd say a decent amount of the time, the response is, I don't know, what do you want to do? And so it's really a group effort in taking care of them, which is really nice. Once they get to be kind of longer term follow-up and they're only coming in a couple of times a year further down the road, then they tend to just see their physicians at that point. But I do like to get to know the patients. It is a field where there is often a lot of mortality and morbidity associated with transplant. And so, and in cancer care in general. But I think that once you kind of understand that that's kind of part of human nature, it's definitely not primary care, but I think that, these patients can all teach us something. And the biggest thing is that I certainly learn more from my patients than I can ever teach them. So, just watching how different people go through probably one of the toughest times in their life has been really informative just in my own life and how I kind of make decisions and deal with things. You see a lot of patients who basically mirror you. You could be you in that bed, and that's important in kind of making your decisions. You have to take into account, we see people who are um, everything from physicians to CEOs to a watermelon farmer, or we've had patients who are homeless, we've had prison inmates, we've had active duty military. You see people just in all sorts of different personal lives and how they need, when all of a sudden their life is completely disrupted and they're kind of put in with us, how they deal with that. So I find it very rewarding. It can certainly be sad and draining at times, but it's one of those things where I think the value we get out of it keeps us all here and keeps us working for our patients as a team. And it's nice because also it's a large group of people who understand that what is at risk with our patients. So everyone works together for the best good of the patient in making decisions. As far as the days, I'm on the inpatient unit now. I can actually show you. I'm in the patient recreation room. There's a nice painting. There's some crafts over there. We let them have a keyboard. There's a computer for them. So this is like their kind of activity room. On the unit, because they live up here basically for a month, we have a room with laundry machines and dryer. We have a room with bunk beds and a shower for families, that when our patients go to the ICU, their families can actually stay up here on our unit to be closer to their loved ones. Every one of the patient rooms is a single room, and they have basically sleeper sofas, so the family member during non-COVID times can stay in a room with the patient and basically stay with them for the month if they want to in the room with them. We have an exercise room as well with treadmills and an air hockey table that absolutely no one plays, which is a shame, except for one of our doctors loves to play it and will challenge his patients. But that's up here. So we will round as a group. We have 2 APPs and a fellow. Generally, when we're fully staffed, a clinical pharmacist that rounds with us, along with some pharmacy learners and the physician. We start and just kind of, everyone splits up the patients between the APPs and the fellow, and we round. We don't have residents or medical students on the team. We will have people shadow during, again, COVID times, but we don't have any on the team like you would see on some of the medicine services. And that's because of the accreditation required for stem cell transplant. We're not allowed to have anyone kind of under a fellow level on the team taking care of the patients because they won't be accredited. The outpatient clinic is a little different. We each have a template. So we come in and we'll see anywhere from, I'd say, 4 to 6 patients in a 10-hour day. So it sounds like very reasonable amount of patients, but some of our patients are, especially in the clinic, a real mess. So they can take anywhere from an hour to an hour and a half of just dealing with the patient, getting infusions going. Sometimes they're on 20, 30 different medications. So that can kind of be extensive as well. We have a clinical pharmacist who's also out in the clinic and works with us too. I'm trying to think. I don't think there's a whole lot else that I do that probably requires explanation that I can think of. So maybe start with some questions and see.
Yeah, we can definitely go ahead and transition to questions. Our first question is, did PA schools have the 1,000 hours of patient contact requirement when you applied? If so, how did you fulfill that requirement before PA school?
So when back in the dark ages when I applied to PA school, it really does feel like a long time ago now. There was different requirements for every school. I imagine that's probably the same now. Duke, I know at the time, so Duke is considered the number 1 PA school. It probably always will be because it was the first PA school in the country, and the founder of the PA profession, Eugene Stead, was at Duke. So they had a 2,000-hour patient experience requirement, which I think was probably the highest that I had seen of any school. Most schools had some sort of patient experience requirement, but they varied by school. George Washington, when I went, actually did not have a patient experience requirement, which was interesting. They based a lot on the interview and some of the other things that they looked at, like testing and some things like that. So every school was very different. There's a centralized application process, which I assume is the same for med schools, where you can kind of go in, fill out a large thing, and then the more money you pay, you can apply to as many schools as you want to, kind of in one big swoop. So I applied to a bunch, knowing that I didn't want to spend any extra years waiting to get into the one I wanted. So even if I didn't get in the first one, but luckily got in where I would like to have gone. So although I was about to schedule an interview out in Oregon, so glad I heard from GW when I did. But yeah, it was all different. So, but I did get, I worked, like I said, for about a year and a half with a gynecologic oncologist as a medical assistant. That job was really nice in that it was a very small office. So it was the physician, a chemotherapy nurse, an office manager, and me. He would see patients in the clinic, he'd give chemotherapy in the clinic. So I did everything from the front desk to helping out the chemo nurse to assisting him with procedures and the exam rooms and rooming the patients and doing all the typical vital signs stuff and all that as a medical assistant. So it was actually pretty useful and helpful, I think. And I convinced him, he didn't have a very high view of PAs. And so I convinced him, and he, after I left, I think about a year later, he got his first PA and wrote me and told me that he couldn't do without her anymore. And so at least that was convincing to someone.
That's awesome. I have the next question. So it says, have you noticed a difference in the amount of autonomy PAs have in a hospital setting versus working in a clinic?
Mm-hmm. It really varies based on which group you're in. I think it has a lot as well to do with how much experience they have working with APPs also. My group is, and it's just the comfort level of a lot of times the supervising physicians. The docs in my group are extremely APP friendly. They hand off all, I mean, they'll let us do almost anything. I've had situations recently where I've had to have end of life discussions with a patient and his family up here on the unit. The doctor was here, but knew that I had a better relationship with the family and the patient. So let me handle that. I mean, some of the things that we have clear roles for, like I am totally happy to have the physician decide the chemotherapy regimen coming into transplant. That's just not even something I would want to do. So it's definitely something where you have to know your role, but we have different groups, and so it's not the case with everyone. In fact, a coworker of mine is in the outpatient clinic, and her physician prefers to go in with every patient after she sees them. Personally, that would drive me absolutely nuts. It's just not how I started out my career. When I was traveling with the Duke Oncology Network, many times I would go down to a clinic by myself and see patients. And so I'd be the only provider in the clinic, and there wouldn't even be a physician there most of the time, actually. And so I just got really comfortable with giving scan results or broaching uncomfortable topics and kind of taking the lead myself. So it would not be the type of job I would want, but this particular friend of mine is totally happy with having her physician go in and likes that kind of relationship. So you can kind of decide where your comfort level is. But in the hospital, it really varies. Some of the teams work very closely together where they kind of have a really close involvement with the physician, and others are a lot more autonomous. Surgery and cardiology are two big areas that PAs go into. There's quite a few PAs in both of those, and surgery in particular can have a really varying amount of autonomy as well. There's a lot of first assist PAs out there where that's just kind of what they do, is they're always in there. And I think it really depends on getting experience, being confident, and building a relationship with the physicians that you're working with.
Awesome. Thank you for that. Our next question is, in order to change fields as a PA, do you have to undergo new training?
No, which is wonderful and frightening at the same time. So if I wanted to, I could put in my notice today and apply for a job in pediatric ophthalmology. Um, it would be rough, and I'm not sure that I could, I think you kind of get the experience, which helps you get different careers. But if someone's willing to train you, you can certainly go into any field. PAs are trained as generalists, so there's a few subtle differences of nurse practitioners and PAs once they continue working. And one is that nurse practitioners specialize in different areas. So you can have a family which can see children and adults. You'll have an adult who can only see adults. Women's health can only see women. There's kind of different tracks. And so as a PA, it's a generalist field. So I board certify in everything, including, which is really rough on the research exams, pediatrics, women's health, lots of these things that I haven't had to deal with in 15 years since I was in my rotations at school. But we do almost like an internist kind of recertify in all those fields.
Thank you. Our next question is, do you work with any RNs, and also do you work with any end of life care teams at all?
Mm-hmm. So yes, 1 second. Sorry, my phone is exploding. Yes, so I work with nurses up here on the unit, obviously quite a bit. So every patient, we have ideally a 3-to-1 nursing to patient ratio on the unit with the transplant patients. So I work with them very often, and in fact, it's also nice. I have a lot more time, I think, with both the patients, but also I work much more closely with the RNs as well, because we're all up here. I'm the one who is entering the orders. If there's a problem with the patient, they come to me. They're not going to track down the physician. So I get to know all them really well. And we have a really fantastic group of nurses up here on the bone marrow unit. We have a few nurses we actually have RNs in the bone marrow clinic as well. There's not as many, there's just a few. And they do our own phlebotomy and our kind of clinic nursing needs. Oh, and the end of life care thing. So we actually have a palliative care team here at UNC that's really excellent. And we have been for years trying to incorporate them much more closer in our management of the patients so that it becomes more routine. We certainly consult them when we need to, but they help with a lot of our symptom management. Most of us are pretty comfortable talking about end of life issues, but we've been trying to get them in earlier in the process to kind of start those discussions when you don't need it, which is the best time to do that. And so we're going to start adding them to kind of pre-transplant visits and just kind of using them as kind of extension of our care as well, because they're a great resource. They have, however, in the recent months been really stretched thin. I think palliative care right now with COVID has been a really tough service. They're just kind of overloaded at the moment, but they're wonderful.
Thank you for that. Our next question is, do you feel your role as a PA has changed due to the pandemic?
Well, so the job has changed. When the pandemic started, everyone panicked a little bit. And so we really decreased our visits. We got rid of all our non-essential visits out of clinic, and we pushed off transplants, which were not urgent. And so all of a sudden our patient volumes decreased. We had hardly any patients, actually. It was kind of crickets up here during April, and then everyone realized they needed to start seeing the patients again because it wasn't just going to go away in a month or two. And so we are now, I think, still catching up. We've been extremely busy. As far as my role, I don't think that we're doing anything differently. It's just a lot more precautions. Seeing the patients has been more challenging just because you can't see mouths and things like that. Communication's been tougher. But we've also had some patients being moved to virtual visits. which is not ideal. Not many of our patients can be. So we're still, unlike a lot of groups, we're still operating fairly normally at this point where we're seeing a lot of patients in clinic. They're just not the type of patients that we can really move to virtual.
Thank you. Our next question, this is kind of a combined question, but it's if you have any social media that people can follow, and then also if there's any books or podcasts that you recommend.
I don't have any personal social media. You don't want to see my kids. So probably not. As far as books or podcasts, I don't really have, not great, but I just don't have anything that I think has been really life altering. I'll read something and think it's great and then forget about it kind of a month later. The terrible thing is too, I try to read, there's a lot of great books about, understanding end of life and those sorts of things, which I have big stacks of at home. But honestly, sometimes people do actually die at my work, and there's terrible news being given, and all you want to do when you get home is read a good murder mystery. Or something kind of trashy on TV. So we do a lot of, in fact, we'd probably look like a bunch of serial killers if you heard the conversations in our workroom. Making a murderer and things like that are big popular topics in our group. So no, nothing useful for career benefit.
Thank you for that. Do you have any advice on how to get HCE/PCE hours during undergrad?
I really enjoyed my medical assistant time, but I think as far as, this pandemic's been rough. I think that's going to be really tough. I hadn't really thought about that before, but that is going to definitely be a challenge. I don't know if there's any way to do things virtually as far as, helping out. The things that were really easy to do are going to be, contact is contact. And so it's going to, I guess, be mostly virtual. I don't know. I'll have to put some thought into that. It's tough. It's tough for all you guys.
Yeah, for sure. I was going to say our next question is, have you ever been so connected to a patient that you actually attended their funeral or wake?
Yes. And that varies on provider too. We have people who I work with who say, I want to have a big separation between myself and the patients. My view is that if I start forgetting that we're treating humans and that they're real people too, then we're not providing them the best kind of care that we can give them. The first patient I actually went to the funeral was actually a year after I was working at the Duke Oncology Network. My supervising physician had been treating a woman with metastatic breast cancer for 10 years. Had known her very well. She was 40, had a daughter with cerebral palsy who was a teenager and severely disabled, and a very sweet husband. And so we got to know their family well, and I saw her quite a bit down in the southern part of the state at one of our satellite clinics. And what really struck me was that, at the very end, when I said, "Oh, these are your liver numbers. This is the point we've been talking about where, there's not any other treatment available." And we talk about kind of hospice care and all that. The husband just looked at me and said, "I've got a question." I said, "Okay, anything." He's like, "I don't know if I should ask it." I'm like, "Please, anything right now. You can literally ask anything." And he goes, "Can we go on a cruise?" So the answer is always yes, of course. At this point, like, the answer is going to be yes to anything you want to do. And he's like, "How about tomorrow?" I'm like, "Sure." So he packed her up on some cruise to the Bahamas. It was like a 3-day cruise. She came back a little less yellow because UV actually takes care of jaundice fairly well. So she had sat on the pool deck and helped with her jaundice, laying in the sun for a bit. But they were just a really lovely couple that we got really close to. And so we went down to to their funeral, my physician and I, but I've been to several. Only usually it's the patients who I've gotten close to both their family and them, and so I go to basically support the family.
Team, third floor, room 3719,
Not me.
bed 2, Anderson Pavilion. Adult rapid response team, third floor, room 3719, bed 2, Anderson Pavilion. Adult rapid
I don't
response
think that's my
team,
patient.
third floor, room 3719.
All right. So our next question is a little bit loaded, so it has a few parts. What is the difference in your role/abilities compared to the physicians you work with? Are there ever times that you wish you had an ability/power that physicians are afforded that PAs don't have? What are some of the responsibilities you don't have and you're grateful is left for the MDs?
So I think the first one and the third one are probably pretty linked. So there's plenty of things that the physicians, I think, to back up a bit, I think that it all comes down to kind of that decision to go to PA school and why are you making that decision. What's paramount in that is to order your priorities. My priorities, I knew going in, were going to be, I wanted to do something I loved. I enjoyed working with people. I really liked medicine. My lower priorities were salary. I didn't want to be destitute or having a hard time paying my bills, but at the same time, that was not high up on my list. And prestige was also very low on my list. So I didn't care about my title. And I think it's important to be honest about your priorities, and some of these things are going to be important, and regardless of where you fall in that spectrum, helps you make your decisions. The physicians, certainly, they're trained longer, particularly in transplant. It's a subspecialty of a subspecialty. They go through 4 years of medical school, then 4 years of residency, and then 3 years at least of fellowship before they can become a transplanter. Sometimes at that point they actually, so that's if they can become a transplanter at all. Most of them actually do an additional fellowship in just bone marrow transplant after that. So they obviously understand the biochemistry behind what we're doing. They understand the cellular nature a lot better than I do. Most of them actually spend the majority of their time in the lab. So their knowledge of kind of the deep understanding of transplant and how it works is definitely much greater than mine. I'm fine with that. I think that, the practical aspects of what to do when someone's having, refractory nausea, or they're showing signs of any of the rare infections that we see, I'm totally comfortable with all of that. And there's only so many things that can happen. So I think my management skills are fine and very more than adequate as far as what we need, but I think the understanding of what goes on, and so understanding all the data, I leave up to the docs. There's a lot of studies. It's changing all the time. We have all these large conferences that come out and pairing one study against another study, and I leave up the decision of should we use this regimen versus that regimen because of a small difference in the data. I'm totally fine. I don't really want to make that decision, and that's definitely better for them. And then tying it into kind of the last question too of, are you glad that they have some more abilities? So the best part, not the best part, not by any means, but a good part of being a PA as well, which I also realized I was comfortable with, is that the buck doesn't stop with me. There is someone beyond me that if I'm not comfortable making a decision, I can just tell them, listen, this is what's going on. What do you want to do? Because technically this is your patient. And so it really, I think that it sounds great to have that kind of responsibility. And there's different levels. Certainly if you start out, all tiers throughout the medical system, but there's a lot of pressure involved in a lot of these decisions, and often there's no right answer. And so you're going with what you think should be done. And in some of those circumstances, really bad outcomes have the potential to happen. And so I feel comforted that there is, someone with even more training than I am to make those decisions when we need to. What was the question in the middle? There was a first and a third, and then there was a second. During COVID, I can't keep anything in my head more than like 10 seconds. So
Yeah, I completely understand that. The middle question is, are there ever times that you wish you had an ability/power that physicians are afforded that PAs don't have?
I can't think of any. And that has a lot to do though with, we've got a really great group and I have a lot of autonomy. There's not a lot that if I wanted to become involved in it or, I can't think of anything I would want to do that I can't already do. I certainly don't want to write the chemotherapy orders. I don't want to apply for grants. I don't want to PI these clinical trials that we have. We have, numerous trials. I don't want to do that. I don't care to head a group or to be a chief or a associate anything. None of those things are kind of important to me. So I don't think so. That being said, like my friend who is out in the outpatient world and whose physician kind of comes in with every patient and that sort of thing, that would, again, that would be something that I would not want to have. And especially in her situation, it doesn't happen in our group because we establish a different expectation and they see our group so much, but in her group as well, she's had many patients who do come to her and say, oh, I'm seeing you today. Why aren't I seeing Dr. whoever? And so there are definitely jobs where that's the expectation set with the patients. And so that would bother me as well. But in my current position, no. In fact, there's sometimes when I would wish that I couldn't do some of the things that I can do and someone else had to do them.
Thank you so much. Sounds like in your current position, you have a lot of balance. So that's really nice. The next question is, do you recommend taking a gap year before applying to PA school or do you recommend applying straight out of undergrad?
I don't think it really matters too much. I think that I took a year and a half mostly because I was coming out of undergrad, not being sure exactly where I wanted to do. And I needed a couple courses like abnormal psych and others, something else. I can't remember now, to meet the requirements. Sorry, they're going to announce it like 5 times.
Anesthesia, 3rd floor, room 3719, bed 2, Anderson Pavilion. Respiratory therapy, 3rd floor, room 3719, bed 2, Anderson Pavilion. Respiratory therapy.
It's never good if anesthesia and respiratory therapy need to go somewhere.
Anderson Pavilion. Respiratory therapy, 3rd floor, room 3719, bed 2, Anderson Pavilion.
Okay, I think we're done. I'm sorry, I even forgot what you were asking me.
It was about the gap year, taking a gap year.
So I took some time. I think I'm a big proponent of gap years. I think if you're going to med school, that question's a little tougher just because you have a lot of years ahead of you. So I think that, that kind of postpones getting to your final destination. For PA school, I think it's great. I think it's a good learning experience and to come in a little bit more in a different mindset of kind of being a employee as opposed to a student. And so when I was in school at GW, there was another program that we worked with often at Howard University in DC. Their program was a little different. Not many programs do this anymore. I don't know if anyone does actually, but it was a 3+2 program, meaning that 3 years undergrad, 2 years of your master's, all kind of jammed into one 5-year program. And so obviously the first 3 years were focused on kind of medical issues as well. But my experience with those students is that they just weren't as confident. They still had I need to take this test and get my A. Whereas in my program, they had a lot more people who had been out working in other careers. And so the thought was more, I just need to be a good PA. That kind of mentality was a little bit different, just because they had had some time away from that intensive, just all the time school atmosphere. But that's my personal opinion. I also think it's helpful to get patient care experience because it's just really tough when you're in school as well.
Do you have any advice on how to find a PA to shadow with at UNC Hospital?
Yes. So we actually have there is an APP center. I'm not exactly sure. I assume you can probably just Google that. Or you can certainly send me, I don't know if you guys can send out my email, but you can send me an email and I can send it to them if there's another APP group you'd like to shadow. I think they've tried to centralize the shadowing for PAs. And then if anyone's interested in transplant, they can email me directly back. So for whenever we can act like normal again. But yeah, the APP Center is working on trying to get shadowing more organized.
Okay, awesome. The next question is, if you want autonomy with patients as a PA, is it easy to find an employer or physician that gives you that autonomy, or is it somewhat rare?
So I think it's twofold. One is that I think it is not rare, but I do think you have to be kind of careful. So I think that during the interview, that's something to really discuss seriously. I also think that for almost any group, personality affects it quite a bit too. So if you're comfortable being autonomous, unless you have someone who's really against it, I think that even if it doesn't start out entirely autonomous, you can certainly move to being more autonomous as kind of confidence grows with both you and your supervising physician. But I think the key is just making sure you're not a scribe. No one wants to go through all that just to write the note. It's the worst part.
All right, I think you have answered all the questions that everyone has asked thus far. So if anyone else has any last and final questions, you can go ahead and put those in the chat. I'm going to give people a second just in case, but
Thanks everyone for listening. This is a pretty cool thing you guys are doing.
Thank you so much for coming and speaking with us. We definitely appreciate it.
So I just saw a quick, if you could do it again, if you had to do it again, would you? And yes. I actually tell people when they're shadowing others, that's a great question to ask. And even more so, a little bit more specifically, what would you have done differently? And for me, other than not working ever in urology, probably nothing differently. But I think that's a good telling question as well.
I actually have a quick question. So one question we had in another call was, if you could give yourself, your younger self, a piece of advice, what would you say?
Probably the biggest thing is not to stress that in rushing things. I think my entire life I was probably always geared towards, I have to make sure I get to this next step. I have to make sure I get to this next step, and not kind of appreciating each step along the way. But I think taking some time to do things that you really want to do as opposed to just jumping in because you feel like you need to get to the next place. That goes to talking of the gap year, or doing things like I took the urologic oncology job because I felt like, oh, I'm never going to get a job, and here's a job being offered. But it wasn't ideal, and if I had just kind of taken a breather, I would have probably moved on to something better. It's kind of like deciding to get married. Like, don't rush it. Wait for the right one. And that's kind of career decisions as well. So
awesome. We actually got one more question, and is, do you think that PAs get more patient interaction / time than MDs tend to get?
For sure. Yeah. I think that in our group, even just our patient slots are an hour long per patient. The physicians are 30 minutes with each patient. But also, we're kind of viewed as being all clinical all the time. They kind of are doing other things too. So I think that we definitely get much more patient interaction.
Awesome.
Awesome.
Oh, sorry.
Go ahead, Mark.
Well, we really enjoyed hearing from you today. Yeah, thank you so much for being here.
Sure, this was really fun. Thanks, guys.
Thank you so much. I think we all appreciated all your advice and answering all the questions so much. So
Sure. Well, thanks for everything. If anyone, feel free to send out my email if anyone has any questions or whatever.
yeah, we'll make sure to send that out. Thank you so much. Have a great rest of your day.
Thanks, you too. Bye.
Thank you.